So we're gonna really start by why is it important to screen for substance use disorders and for co-occurring psychiatric illnesses, and then we're gonna go a little bit into some of the recommended models for screening and assessment, and review some of the common screening tools that may be used in primary care and specialty settings. Right. So I think this is slightly older data, but it really does demonstrate just how common substance use disorders are and remain, right, in our country. And really, there is a good reason to be concerned because over COVID, over the pandemic, over the last 2-3 years especially, we have seen, not just in the United States, but also globally, rising rates of substance use disorders. And at the same time, very few people who need treatment for substance use disorders actually are able to access treatments for substance use disorders, right? So, and this number is actually held quite steady. If I'm going to pull my fancy little laser pointer app tool here, but you can see about 10% of those needing treatment actually receive specialty treatment. And that number has been very stubborn. We haven't been able to budget all that much over the last even, I think the most recent I saw was around 11% or 11.3%. So it hasn't changed very much, right? And there are many reasons why this happens. So obviously we're missing the opportunity to help a lot of people who could benefit from that help. And stigma consistently rises to the top of this, right, as to why people don't access treatment. Some of the other common reasons why treatment access is so difficult include the cost of treatment, right? The lack of interest. Some people aren't interested in it. They don't necessarily feel ready for it, or the lack of availability. As Dr. Lindsay often points out, behavioral health workforce, there is a huge shortage around the country and especially in rural parts of the country. And that further makes it challenging to seek treatment. So these are some of the things that were brought up. But on the other hand, primary care and emergency departments are much more widely accessible to many people, especially primary care, right? You can see that a majority of US adults and children see a healthcare professional, right? Usually in a primary care setting, occasionally in an emergency department setting. So that's the opportunity. That if specialty addictions treatment, specialty substance use disorders treatment is so hard to come by, but people are more readily able to access primary care in particular, right? Is that an opportunity to then catch or somehow connect with people who may never go or may never be able to go see a specialty addictions treatment clinic? And also people whose substance use disorders maybe haven't progressed to a point where they necessarily require this hard to come by specialty treatment, but effective interventions may be made at a sort of a lower level of care, in a more easily accessible level of care. And that really is behind the heart of screening. And some of the models that I know the slides will describe, including SBIRT, right? But we can't start to help these folks unless we start with screening and assessment first, right? So what do screening and assessment do? Well, they help us understand, help providers understand what the patient's needs may be, and ideally match them to the appropriate level of care. It also helps providers track symptoms over time. Are the treatments working? Are interventions helping? Are they not helping? Etc. All right. And over time, the clinical care sort of has shifted from a complications-driven treatment, or hopefully this is shifting, where nothing is done, no diagnosis of substance use disorder is made until something happens, right? Until there are complications of that substance use disorders, right? And then you treat those complications. For example, no treatment is provided until someone winds up in alcohol withdrawals, and they wind up getting admitted in delirium tremens, for example. And then that complication is treated, and then the patients are discharged without any ongoing treatment. Unfortunately, if this is the model that's followed, as we talk about, in many of our talks, we cannot expect an optimal outcome. Relapse is very likely. Patients are very likely to return to their substance use disorder. On the other hand, really the ideal model, as sort of recommended by most major professional bodies, is diagnosis and program-driven treatment, where an appropriate diagnosis is made. For example, for opioid use disorder, treatment is provided. and right in a continuous ongoing basis. And if there is a relapse, I think, that itself minimizes the chances of a relapse. But if relapse does happen, which is not unusual, the treatment is continued or patient is once again continued in treatment, right? And our present really is this client-directed, outcome-informed treatment. And this is really kind of where we are, where client, it's patient-centered. The client has a lot of say in what treatment they may receive, right? There is a full biopsychosocial assessment. Usually treatment is interdisciplinary, right? Comprehensive. Problems or priorities are identified with a lot of input from the client, and a plan is made, and that, that can address all of those areas of need, and progress is assessed on an ongoing basis, which allows us to then further tailor the treatment itself, right? So how can we begin? This is really, I think, at the heart of it. We often think about an episode of care, which is defined as a set of services that are provided to treat a clinical condition or procedure, right? So kind of this episode where someone receives the specialty care they may need, for example, and the episodes may be 4 to 16 weeks in duration, depending upon, again, the comprehensive needs of the patient. And then the post-patient is reassessed and further treatment planning is done. So again, that periodic reassessment to always be checking in and making sure that the client is receiving the services they need. They're matched to the correct level of services. And continuum of care really refers to the idea that with all chronic diseases, chronic illnesses, such as substance use disorder, right? Hopefully there are multiple levels of care, some more intense, some less intense. Perhaps there is an inpatient component, right? Perhaps there is an outpatient component, and patient flows hopefully seamlessly and transitions seamlessly through these different levels of care, depending upon the patient's needs, right? And in an ideal world, again, there aren't drop-offs or discontinuation or interruptions in care as this process moves forward. So this is, I think, an important slide, because if we think about most people, right, with a substance use disorder, right, majority of people are either going to be low risk or full abstainers, right? And certainly no intervention is needed. We provide a positive health message, right? Keep checking in on them. Then there are going to be kind of higher levels of risk, right? About 9%, 10% of people falling into that risky category, right? Another about 8% in the harmful category, and really about 5% of people having a substance use disorder or a dependence diagnosis, kind of as the tip of the pyramid. But ideally, we start interacting and intervening before it gets to this level 4, right? Before this substance use disorder dependence has developed, at which point certainly it's appropriate to refer them to specialty treatment. I think here CD stands for chemical dependency, sort of an older terminology, but really referring to specialty treatment. But ideally, we also intervene in people who may be at a higher risk. Now they're starting to display some risky behaviors, but they don't meet criteria for a substance use disorder yet, which, as you can see, is a substantial proportion of the population who may come in contact with a primary care provider. And there, a brief treatment, a brief intervention can often be a very appropriate way to go, right? So that's really the idea, again, matching it to the correct model. And ASAM, which is American Society of Addiction Medicine, has released their criteria to allow us to appropriately match patients to the level of care. And that very much kind of goes along with this, that we want to match people to appropriate care. It is compliant with DSM-4, right? And many states, including us here in New Mexico, use ASAM's patient placement criteria as sort of a fundamental way to match patients to the level of care they need. And as you can see, it's quite widespread. There are also other models there, but this is probably the quite a widespread model. So what is it? What is ASAM's patient placement criteria? So again, it really looks at a few different things, right? So it starts with screening, as I mentioned. Unless we screen, we have no idea that something might be going on or something might require an intervention, which then leads to diagnosis. Then there is an assessment of severity, readiness, and also relapse prevention, right? And the key thing again with ASAM criteria is that this assessment is whole person. You're not just looking at the medical comorbidity, the diagnosis, but you're looking at the substance use on several different domains, including intoxication and withdrawal, right? Including other biomedical factors. For example, other illnesses that might be present, like acute pneumonia, for example, emotional and behavioral dimension, right? Their treatment compliance, their resistance, how open are they to receiving treatment, their relapse potential, and also their recovery environment. What is home like? Are they around people who are using? Do they have a stable, supportive place to live? Do they have are they meaningfully engaged in community? And those are all the dimensions that go into ultimately deciding what level of care the person needs, starting from an outpatient level of care all the way to kind of medically managed intensive inpatient, right, where there is medical services around available, around the clock to monitor the patient. And that's how it is really determined. I can tell you, and this is sort of the different numbers that you may have seen that go along with it. So I think it's a spectrum, right? And that's really there for reference. I can tell you that one of the things that we really struggle with in New Mexico, right, and going from acute detox to inpatient, residential, and outpatient treatment is, just how difficult it can be to access treatment, especially at those higher levels of care. And I think many of you who are on here can relate to that, especially those of you who are in rural communities or frontier communities. Despite our best efforts, it can actually be quite difficult to match people to the right level of care simply because those services may not be available. And I think there's consequences to that. And I think that's why I think there is so much effort and so much stock put into building this comprehensive system of care. Because what this study is really showing is that when patients are matched, which is the kind of this tan bar, as opposed to when patients are not appropriately matched, right? They're undermatched, outcomes are worsened. Here it shows that no-shows are higher, right? No-show rate is significantly worse with various substances, including cocaine and heroin. So patients are less likely to engage in care appropriately if they're undermatched, right? And this is also looking at other outcomes, including retention in treatment, which is one of the big parameters we look at, or percent dropout, subscales of the addiction severity index, right? The higher, the better there. And people who are ready for step down, so stepping down at a lower level, where again, I think if patients are undermatched, outcomes worsen. So we really do want to match people, make every effort we can to match people to the correct level of care, right? And ASAM criteria, again, are a good way to assess for this because they have quite a bit of validity involved. That brings us to the SBIRT model, something else that you may have heard about, something else that's talked about quite a bit. And SBIRT, of course, stands for Screening, Brief Intervention, and Referral to Treatment model. Screening, right? Starting with screening, using standardized screening tools, which we'll go into. Brief intervention, really for those people at those risky or hazardous levels of use who may be amenable to and who may benefit from relatively brief interventions, which are evidence-based. They usually include some element of providing feedback. We often include some element of motivational interviewing or motivational enhancement therapy. Often interviews sort of assessing where the use is, what the goals are, exploring strategies to meet those goals. So relatively brief, but can benefit many people in that risky range of substance use. And finally, for people who really are already at a substance use disorder or more severe substance use, referring them to treatment. Again, using the ASAM criteria in an ideal world to match them to the correct level of care is the way to go, right? Some of the essential elements, as we talked about. So what does brief intervention look like? There's actually some really good YouTube clips that demonstrate this. Dr. Lindsay has listed here the SBIRT app, which is on iTunes, for example. So there are lots of resources there. And there are different ways to approach brief intervention, but in general, some of the common elements of it include, getting information, right? Eliciting that information from the patient and providing immediate feedback. For example, well, this level of drinking, you're telling me you're drinking about 6 drinks a day, going through a 6-pack of beer daily. Well, that's really more than 90% of people, and that puts you at risk for all of these things, right? Liver damage, developing substance use disorder, hypertension. So providing that feedback with permission, understanding the patient's views, again, eliciting that information, understanding what the patient's view is, and then coaching them to change their perceptions about their use. Encouraging, eliciting information, all those things that they don't like about the use, things that may have led to injury, what they like, what they dislike, what are those change points are, advising patients in clear but respectful terms that, I will often say in brief intervention models that as your physician, I do advise that we work together to see how we can best reduce your use of alcohol, for example. So kind of that direct, advice is often a part of brief intervention models. Teaching behavior change skills, what's going to work, what's not going to work, what are going to be some barriers, and following up. That's your brief intervention, and often can be quite effective. And again, this is just that idea that with screening, depending upon what their level of risk is, we match that to the level of care or treatment that is then provided, right? Moving forward to screening. So how do you then apply these models? What are some screening tools? So screening is the first part, right? Often a question that comes up is screening versus assessment. And screening is we want to target any unhealthy or problematic substance use. We want to detect anywhere along a spectrum of unhealthy use for various substances. Right, so usually happens early in care. It's quick. It's usually, kind of preliminary, and allows us to track symptoms over time and also allows us to refer to treatment. By contrast, assessment happens after screening. It's more comprehensive, right? Where we're getting more information, that key information. So screening is that quick early process. Assessment usually follows. It's more detailed. And really the idea is to also come up with diagnosis. What diagnoses might exist? What is the individual's level of change? What are some strengths? What are some problem areas? And start to establish that treatment relationship. There are many screening tools out there, and these are some of the ones that are listed here, that are validated, including, for example, some of the big ones are Audit and Audit C for alcohol, really good ones, right? NM Assist, which stands for NIDA Modified Assist, which actually allows one to screen for a variety of different substances. And there's computerized electronic versions available, for example. So we're going to go over some of them relatively quickly. One is the CAGE questionnaire, which is really just 4 screening questions. This is often used, I know, in primary care settings to screen someone's alcohol use. It's 4 questions, and if someone answers yes to more than 2 questions, it is suggestive of a lifetime diagnosis of a substance use disorder. So it's, again, quick. It's just 4 questions, but allows one to pick it up, right? And these are the 4 questions here listed. Have you ever felt you should cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt guilty about your drinking? And have you ever had a drink first thing in the morning, or an eye opener? Audit and Audit C. Audit stands for Alcohol Use Disorder Identification Test. I really like it. Audit is 10 questions. Audit C is 3 questions, but it is highly sensitive and specific for indicating risky drinking. And you can see, and again, these are all available for reference. The full thing is the audit, and Audit C is just the first 3 questions, right, that are listed here. How often do you have a drink containing alcohol? How many units of alcohol do you drink on a typical day when you are drinking? And how often have you had 6 or more units if female, or 8 or more if male, on a single occasion in the last year? And just those 3 questions allow us to really pick up heavy drinking. And if it's there, then we really start going into more detail. This is a similar DAST, which is the drug abuse screening test. Comes in 10 and 20 item versions. Again, a quick screener for a variety of substance use disorders. For me, the one I like the most, the screener I like the most for alcohol use is Audit, And the one I like the most for other substances is the NM assist, the NIDA modified assist, which is web-based, it's interactive. It's 8 questions that evaluate 10 different substance classes. So there, and I've included actually here a link to it, through the drugabuse.gov. So if a patient's in your office, you can even work through this with the patient. These are a little bit different, right? These are symptom trackers. COWS, of course, tracking opioid withdrawal symptoms, and SIVA, which tracks alcohol withdrawal symptoms, very commonly used ones. We do a whole other talk. Dr. Warwick, I know, has done a wonderful talk. So just a reference slide that another, I guess, a screening would be urine drug screening, right? Which also is technically considered a screening tool to allow us to track objectively what substances might or might not be used by a patient. And then there are mental health screening instruments, including the WHO quality of life brief, which gives you an idea of overall general health, PHQ-9 for depression, GAD-7 for anxiety disorders, PCPTSD for post-traumatic stress disorder, as well as HUDAS and QOL quality of life. And again, all of these are public domain available through SAMHSA, depending upon what the need might be. I know in primary care, right, although beyond the scope of this talk, PHQ and GAD-7 are widely used for depression and anxiety screening in particular, right? So if someone screens positive, for example, for a substance abuse, right, substance use, again, that quick early screening, then assessment is where we're going to turn to. Assessment, again, is comprehensive. And these are all the things we're going to go through, right, in a full assessment, which is the gold standard. And very often, if you're a multidisciplinary, interdisciplinary practice, this is where it makes a lot of sense to rely upon your behavioral health team, for example, or your colleagues who may come from different professional backgrounds to gather this full assessment, right? There are some assessment tools that are out there. I know addiction severity index is something that's quite widely used. For example, I use timeline follow back a lot for some of our research studies. So there are many of these out there. But again, assessment is the more comprehensive piece. The whole process, of course, starts with screening. So I will end here. I was hoping to end by 12:30 for sure, and I think we are there. So I will stop slides here. Yeah.